So when you're in the earliest stages of chronic kidney disease, it's primarily managed in primary healthcare with GP, practice nurses, community nurses, and so forth. And the goal is to reduce the progression of chronic kidney disease to more advanced stages and to reduce the cardiovascular risk. And we do know that lifestyle modification is really, really important in this stage, in these two stages, and this is where nurses have a massive role to play. And people are 20 times more likely to die from cardiovascular disease than progressing all the way along to needing dialysis or a transplant. Similarly, in stage 3, still in primary healthcare with GP, practice nurses, maybe even nurse practitioners are involved here, and the goals are very similar, but also need to avoid medications that are toxic to the kidneys. So this is where your pharmacology comes in. We need to avoid the non-steroidal anti-inflammatory drugs, the Nurofen, the Voltaren, all of those sorts of things, as well as some of the antibiotics, the aminoglycosides should be avoided, so the gentamicin and so forth. Sometimes patients in this stage are referred to a nephrologist or a CKD nurse practitioner. When somebody's in stage 4, they're usually under the care of a specialist renal team. It does involve nurses, such as nurse practitioners and clinical nurse consultants and clinical nurses. And here, similar goals as what I've just showed you, but here we're also starting to prepare people for kidney replacement therapy. Kidney replacement therapy is the current name that we use to describe hemodialysis, peritoneal dialysis, and kidney transplantation. And some people in this stage might have a preemptive kidney transplant, in other words, before needing to go onto dialysis. And then in stage 5, this is end-stage kidney disease or kidney failure managed by a renal unit. It's highly complex care, and the kidney replacement therapy is absolutely needed. And people are also given the choice not to start dialysis, not to have a kidney transplant, and this is what we call conservative care. So we do know the major causes of stage 5 chronic kidney disease. There's an annual report of every single patient that has dialysis or a transplant in Australia and New Zealand. It's called ANZdata. It's a lovely, great website. And you can see these are the causes of kidney failure. So these are the patients who have gone onto dialysis or have had a transplant. And you can see how common diabetic nephropathy coming from diabetes, mostly type 2, is causing our patients to need dialysis. Glomerulonephritis, hypertension, and then some other causes of stage 5 chronic kidney disease. What we know is that as kidney disease gets worse, more and more symptoms come in. And what you can see on this graph, the orange is terminal cancer symptoms. The pale bluey green colour is terminal kidney failure or end-stage kidney disease symptoms. So people are alive on dialysis, having a transplant, or getting conservative care, and their symptoms are much worse than cancer patients who are in their last months of life. Because we have dialysis, it keeps people alive. So some of the important things are around fluid restrictions and dietary restrictions. And I don't have a lot of time, so I won't go into all of these. But the most important thing to remember as a nurse is watch that fluid that goes into patients, okay? Be very careful with IV fluids in particular. Also look out for potassium levels, because it's very easy for a person with advanced chronic kidney disease to have a very high potassium level, and they will cardiac arrest on you if the potassium is too high. People with chronic kidney disease take lots and lots of medications. They will have the most long medication list that you have probably ever seen, and I've just got listed there some of the most common medications. Most patients have a pill burden of well in excess of 20 tablets a day. So conservative care is for people who decide not to have kidney replacement therapy, or perhaps they're medically unsuitable for kidney replacement therapy. It's holistic, patient-centred care, and it really involves shared decision-making, active symptom management, and being aligned and attuned to supportive care needs. And so conservative care can be needed for many, many years. We know people with end-stage kidney disease can be alive 3 years later, even by not starting dialysis. A little bit about the health disparities. Australian and New Zealand, Aboriginal, Torres Strait Islander, Maori and Pacifica populations are disproportionately affected by chronic kidney disease. About 9% of Aboriginal and Torres Strait Islander people in Australia have kidney failure, but they are only about 3% of our total population. So the incidence of end-stage kidney disease is 8 to 30 times more than the non-Aboriginal population in Australia. The highest rates are in Alice Springs. Alice Springs is world famous now. It's ranked #1 in the world for kidney failure. This is terrible. It shouldn't be allowed to occur. And it's because of hypertension and diabetes, predominantly in our Aboriginal and Torres Strait Islander people. What we also know is they're less likely to receive a kidney transplant. There are a number of issues associated with that, and we're trying to close that gap. And about 50% of Indigenous Australians are required to relocate to urban or regional areas just to get dialysis. So imagine having to move away from your home, your country, to just have dialysis treatment. So why do we start dialysis or kidney replacement therapy? Well, it's to prevent death. If we didn't do it, a person would die. It's used to control fluid overload, hyperkalemia, uremia, manage hypertension, and metabolic acidosis. Count those little bullet points. There's 5 there. And right at the beginning, I said there were 7 functions of the kidney. Can you think of the 2 functions that kidney replacement therapy, dialysis, does not do? I'll just leave you with that question. So kidney replacement therapy is peritoneal dialysis, hemodialysis, kidney transplantation only for end-stage kidney disease. And in intensive care, we can do continuous renal replacement therapy. So a little bit about PD. Here we use osmosis and diffusion. Simple. It's as simple as that. If you understand osmosis and diffusion, you understand how PD works. We basically create a concentration gradient across the semi-permeable membrane, which is the peritoneal membrane. Fluid is run in, allowed to sit in the abdominal cavity for 3, 4, 6, 8 hours, and then it is drained out. So there are a couple of different types. There's continuous ambulatory peritoneal dialysis, where the fluid is run in and then it's left inside. It's disconnected from all of this tubing and then reconnected up and drained out later in the day. Patients are taught how to do CAPD by registered nurses and undertake the procedure at home. So PD equipment doesn't need a lot of equipment, and yeah, I won't go into any more of that. And here's a picture of a lady with a PD catheter, and here she's just sitting in the kitchen draining out the fluid that was in her abdomen for the previous 3, 4, 6 hours. So the sequence is drain out first. That means you're flushing away any microorganisms when the patient has attached it together. Drain in the bag, disconnect, throw away these 2 bags and these extra bits of tubing. Then you're just left with this bit with the cap on the end. And you go about your job, work, school, retirement, go and play golf, whatever. Come back, drain out, drain in, disconnect, go about your business. So the advantages are you can do it at home, greater independence, there's less restriction, but you have to do 4 of these exchanges every day of the week for the rest of your life. And there's a permanent catheter. Then there's automated PD or APD. This is where a device called a cycler will do the exchanges and will do it overnight. And it's really good for children, and it uses the same sort of principles of running in and out fluid overnight. So before going to bed, you connect up and connect the tubing. The machine will warm the fluid as it's run in. There'll be tubing running along the bedroom floor into the bathroom to drain that fluid out. And in the morning, the patient disconnects from the machine. So hemodialysis, a little bit more complex than PD. It involves diffusion and osmosis and ultrafiltration. Now, diffusion and osmosis is through a concentration gradient across a semi-permeable membrane, which is a dialyzer or an artificial kidney. Ultrafiltration just means we're pushing that concentration, pushing that fluid, and it pushes across the semi-permeable membrane. But first you need vascular access, and this is where a fistula comes in. And this is a joining together of an artery and a vein by a surgeon, usually in the forearm, but it can be in upper arms or legs. And you can see in the little diagram, the artery is now attached to the vein, and the vein is the thing that sticks up under the skin, and that's what we stick needles in for dialysis. So the join was down here in the wrist, and this lovely vein has come up, and we've put in 14 gauge needles, much larger than you would use for injections. And the needle that's closest to the anastomosis, so the needle would be down here, it brings the blood out and goes round the extracorporeal circuit, the dialysis circuit, where diffusion, osmosis and ultrafiltration occur. And then the fluid is run, the blood goes back into the person and the vein up here. So the blood flow rate is around about at least 300 mils per minute. We work in mils per minute in the dialysis unit, not in mils per hour like you see on your IV pumps and so forth. So it's really important that the fistula is working, and this is where you check for patency. That is called a thrill and a bruit. You feel a buzzing or tingling over the anastomosis site. How do you find the anastomosis site? Look for the scar, the wound scar from the surgery. Bruit, you listen to it at that same spot and you hear a whooshing sound through the stethoscope, and it's a sound rather than that pulsating sound that you get when you take a blood pressure. So on the fistula limb, you never, ever allow venipuncture or IV cannulation. You never, ever take a blood pressure reading, put a blood pressure cuff on that arm where that fistula is. And you never wrap round bandages or anything like that, because you will block off the fistula, you'll block off somebody's lifeline for dialysis. If you don't have dialysis, you die. So this is an artificial kidney, a dialyzer. It's made up of lots and lots of hollow fibres. Those fibres are as thin and as fine as your strand of hair. If you get one strand of hair, you've got the equivalent of one strand that appears inside a dialyzer. So hemodialysis is normally 3 times a week, normally about 4 hours. Some people often could be a little bit longer. It can be done in hospitals, so we call that in-centre hemodialysis. It can be in standalone satellite dialysis units or satellite dialysis, or at home. And so in most dialysis units, it's registered nurses involved. You often don't see any medical staff there, even in centre, and nurses train patients to dialyse at home. So essentially the needle, arterial needle is here, blood pump is moving the blood around the extracorporeal circuit, and here is the semi-permeable membrane, and the dialysis fluid goes in counter-current to the flow of the blood, and this increases ultrafiltration. Now, remember the counter-current mechanism from the loop of Henle? Same sort of principle going on here. So, advantages of hemodialysis: no excess tubing. You don't need to do it every single day of the week like PD. You only need to do it usually 3 times a week, unless you're doing it at home. Some home patients do their dialysis 4, 5, 6 times a week. The disadvantages is that a machine is needed. You usually have a local anaesthetic injection, then the cannula inserted. And remember, you need 2 cannulas, so that can be up to 4 needles needed every time you have treatment. You often feel very weak and tired after treatment and not much good for doing anything else. So the wastes and toxins build up between treatments, and it's not as evened out like peritoneal dialysis is, because there are days on dialysis and days off dialysis. And as you can see from this, you could be dialysing right up to Christmas. But I'll give you a handy hint here. One of the reasons I'm a renal nurse is that when you work in a dialysis unit, there's usually no night shifts, usually no Sundays, and you never work Christmas Day. Come and be a renal nurse like me. So the last one is kidney transplants. And basically there are several different options available for a kidney donor. It could be come from a living person who's donated a kidney, and that could be a relative, so related, or unrelated donation. So often you would see a wife donate a kidney to a husband, or it could be a mother donating a kidney to their child. I deliberately said that because most living donors, about 80+%, tend to be women. Why? I'll leave you to think about that. Then there are cadaveric kidney donors. So these are people who might have signed an organ donor card, or their family were asked in the situation of brain death, sudden brain death, and they might donate their kidneys. But also donation can occur after cardiac death. The key thing with the person who has the chronic kidney disease, their own original kidneys are not removed. They remain where they are, and the donor kidney is inserted into either the left or right iliac fossa. So here's a diagram of a donor kidney put in to the iliac fossa. The normal kidneys are still there, and by the way, they'll be much shrunken because the person has kidney failure. And here's just a picture of a patient that I looked after who had a kidney transplant.